Welcome to the Hospital Medicine Unplugged podcast. We are undertaking a deep dive today into one of the most acute, resource-intensive scenarios we manage on the hospital service, the patient presenting with acute hematemesis. And we'll explore the complex, structured approach required for optimal outcomes in upper gastrointestinal bleeding.
Yeah, this is truly a critical topic. Upper GI bleeding, or UGIB, isn't just common, it's a real clinical emergency. The data confirms it's still a leading cause for GI-related hospital admissions. We're talking well over 500,000 hospitalizations every year just in the US. And given the potential for massive hemorrhage, the associated mortality rates are, well, significant. They range from 2% up to 10%. That really highlights why those first few hours of management are so crucial.
So let's establish the clinical scope right away. When we use the term hematemesis, what exactly are we defining?
We're defining it specifically as the vomiting of fresh red blood or what often looks like coffee ground material.
And that distinction, fresh blood versus coffee grounds, that gives us an immediate clue, right, about the rate and maybe the timing of the bleed.
Exactly. Fresh red blood suggests a more brisk, maybe ongoing bleed, while the coffee grounds mean the blood has sat in the stomach, mixed with acid, so the bleeding might be slower or perhaps it stopped. But the implication is the same. This is the cardinal sign of UGIB. The bleeding source is somewhere proximal to the ligament of Treitz.
And that anatomical location is key because it points us towards the likely causes, the etiologies, and that then dictates our specific interventions.
Precisely. We know the most frequent cause, accounting for, well, a massive share, up to 50% of cases, is peptic ulcer disease, PUD.
50%, that's huge.
It is, and fundamentally it's a failure of the mucosal defense, usually driven primarily by Helicobacter pylori infection, which weakens that barrier, or increasingly common these days, the use of NSAIDs, NSAIDs. They directly erode into those submucosal arteries.
Okay, so PUD is the most common. But we always have to keep a high index of suspicion for the second major cause, right? Especially if there's any history of liver disease, variceal bleeding.
That's the other big one, and it carries a much higher mortality risk, particularly in patients with known portal hypertension, usually from cirrhosis.
So how does variceal bleeding differ pathologically?
It happens in the setting of that high portal pressure. It causes these fragile submucosal veins, the varices, to form, and under stress, they eventually rupture. The bleeding from varices tends to be far more massive, often much harder to control than your typical PUD bleed.
Right. Beyond those two heavy hitters, PUD and varices, what are the other significant contributors we need to consider in the differential, even if they're less frequent?
Yeah, there are others that are still clinically important. We see erosive gastritis or esophagitis, often related to, again, sustained NSAIDs use or high alcohol consumption. Similar mechanism to PUD, but usually not as deep. Then you have the sometimes dramatic presentation of a Mallory-Weiss tear. That's a mucosal laceration, usually after forceful retching or vomiting.
Ah, yes, the classic history there.
And finally, the less common but often quite devastating sources. Things like GI malignancy or specific vascular malformations like a Dulafoy's lesion. That's a small rogue artery that can bleed catastrophically if the overlying mucosa erodes.
Okay, so given this potential for rapid collapse and those mortality numbers you mentioned, our initial hospital mission has to be structured. Aggressive even.
Absolutely. It requires rapid stabilization, a rigorous evidence-based risk stratification, immediate pharmacologic support, timely endoscopic therapy, and critically, a solid plan for ongoing prevention. And all of this really starts the moment they hit the door in the ED within that first hour.
So let's move right into that immediate assessment and resuscitation. That first hour is about triage and keeping oxygen flowing, right?
Exactly. The absolute first step is assessing hemodynamic stability. We're looking at vital signs, of course, but also subtle things, orthostatic changes, any rapid change in the patient's mental status. That's an immediate red flag for cerebral hypoperfusion, for shock.
And on the physical exam, what are we specifically hunting for?
We're looking for evidence of acute hypovolemia. So tachycardia, hypotension, obvious postural changes in blood pressure or heart rate, and measuring output is key. Decreased urine output signals poor end organ perfusion.
In terms of the history, we need to try and quantify the bleed, understand its nature. You mentioned fresh red versus coffee grounds earlier.
Right. Fresh red suggests brisk, maybe ongoing hemorrhage. Coffee grounds indicate slower or maybe prior bleeding as the blood's been altered by stomach acid.
And we can't forget the rectal exam, can we?
No, absolutely not. It's a focused but vital part of the physical exam here. We assess for melena, that classic black tarry stool that strongly points to an upper GI source, or sometimes frank hematochezia, bright red blood per rectum.
While melena is classic, hematochezia doesn't rule out an upper source, does it?
Correct. A massive, very brisk UGB can actually present as hematochezia because the transit time is just too fast. So we should never rely solely on stool appearance to rule out an upper source, especially if the patient is unstable.
Now, it's also important to mention things we don't routinely do anymore based on current evidence, like placing a nasogastric tube for diagnosis.
Precisely. That older practice, NG tube lavage to confirm blood or clear the stomach, it's largely discouraged now. The incremental diagnostic benefit is pretty low, and there's a real potential for harm risk of perforation aspiration, especially in an unstable patient. We focus instead on getting to definitive diagnosis with endoscopy once they're stable.
Okay, so simultaneous to the physical assessment, we need IV access and labs. What are the key lab markers we need immediately, and are there any pitfalls to watch out for?
The required labs include a complete blood count, the CBC, and here's the pitfall. The hemoglobin might be deceptively normal initially, or only slightly low.
Why is that?
Because the patient hasn't had time to equilibrate fluids to achieve hemodilution. It takes time for the fluid shifts to lower the HGB concentration. We also need a metabolic panel looking closely at BUN and creatinine. A high BUN relative to creatinine, often a ratio over 30.1, is highly suggestive of UGIB.
Because of digested blood proteins being absorbed.
Exactly. Digested blood proteins get absorbed in the gut, raising the BUN. We also need liver function tests to screen for underlying cirrhosis, which points towards varices, and a full coagulation profile, the PT, APTT, and INR. And finally, getting a type and cross-match isn't optional. It's mandatory for any unstable patient. You need blood ready.
For the acute resuscitation itself, prompt IV crystalloids are key. Isotonic fluids like normal saline to restore volume quickly. But maybe the most debated point is the transfusion threshold. What's the current thinking?
Yeah, the standard of care has definitely shifted. It's moved towards a restrictive strategy. We generally recommend transfusion only for a hemoglobin less than 7 grams per deciliter in most stable, non-cardiac patients.
And that's based on solid evidence.
Very solid. Backed by landmark trials like the 2013 NEJM study by Villanueva and colleagues. It showed that a restrictive threshold, keeping HGB above 7, actually improved outcomes. It reduced rebleeding and improved survival compared to a more liberal approach aiming for above 9. The thinking is, giving too much blood too quickly, especially if it's variceal bleeding, might actually increase portal pressure and provoke more bleeding.
That's a huge paradigm shift. We're not just chasing a higher number anymore. But you mentioned a critical cardiac caveat.
Yes. For patients with known cardiovascular disease, maybe pre-existing ischemia or an active acute coronary syndrome, we raise that threshold slightly. A higher goal aiming for hemoglobin above 8 grams per deciliter is recommended there. To mitigate the risk of cardiac ischemic complications, it acknowledges that the strict restrictive strategy might not be right if oxygen delivery to the heart is already compromised.
Makes sense. And since we're dealing with active bleeding, correcting any underlying coagulopathy is vital, right?
Yeah.
Especially before endoscopy. What are our targets and preferred agents?
Absolutely vital. We're targeting an INR of less than 2.5 before the scope. To get there rapidly, particularly in patients on warfarin, we now prefer prothrombin complex concentrates, PCC, over fresh frozen plasma, FFP.
And why the strong preference for PCC in this acute setting? What's the advantage?
It really comes down to speed and volume. PCC provides concentrated clotting factors to ESA and IX and X in a much smaller volume. This achieves faster correction of the INR. FFP, on the other hand, needs thawing. It carries a significant volume load, which can be risky, and it just takes much longer to reverse the coagulopathy. That delay can be detrimental when someone's actively bleeding.
Okay, so PCC for rapid INR reversal. What about platelets?
Platelet transfusion is generally reserved for specific situations, counts below 50,000 per microliter, or for patients with known platelet dysfunction who are actively bleeding, regardless of their antiplatelet medication status. We need to be judicious about platelet use otherwise.
Right. Once stabilization is underway, the next phase is rigorous triage. This informs where the patient goes, how fast intervention needs to happen, and this relies heavily on validated scoring systems.
Yes, risk stratification is the key to using resources appropriately. Does the patient need the ICU? Can they go to a standard floor? Or are they stable enough maybe for an observation unit? The Glasgow Blatchford score, the GBS, is really the foundational tool here. It's specifically designed to predict the need for intervention.
Let's break down the GBS. What components does it use?
The GBS uses clinical markers like systolic blood pressure and pulse, along with initial lab data blood urea, hemoglobin, and clinical signs like the presence of melena or syncope or underlying liver or heart disease. It's highly sensitive for identifying patients who will need a hospital-based intervention, meaning either transfusion or endoscopic therapy. The major strength is its ability to identify low-risk patients. A GBS score of 1 or less reliably flags those who might be candidates for quicker discharge or even outpatient management, assuming endoscopy confirms low-risk findings.
Okay, so GBS predicts need for intervention. How does that differ from the AIM-65 score?
Yeah.
It serves a different purpose, right?
Exactly. AIM-65 is much more focused on predicting mortality and overall systemic risk. Its components reflect that. Albumin less than 3.0, INR greater than 1.5, altered mental status, systolic blood pressure less than 90, and age 65 or older, AIMS 65. Notice it includes factors like albumin and mental status, which point to underlying chronic disease and organ failure. It's generally considered the most accurate score for predicting in-hospital mortality and the need for ICU admission.
So GBS for do they need something done now? AIM-65 for how likely are they to die? Awesome. Where does the older Rockall score fit in this modern workflow?
The Rockall score, while historically important, has limitations for initial triage. It actually incorporates both clinical data and endoscopic findings. So the full Rockall score can't be calculated until after the procedure, limiting its use for pre-endoscopy decisions. While the clinical Rockall score exists, the GBS is generally superior for that initial triage step, predicting the need for intervention because it incorporates that initial blood loss assessment more effectively via hemoglobin and BUN.
And we should probably mention there's ongoing work here, right? Newer scores like Harbinger, which is simpler, only 3 variables, and H3B2, focusing on hematemesis, heart rate, hemoglobin, blood pressure, and BUN.
Right. The trend is towards finding even faster, perhaps bedside tools to really refine predicting who needs that emergency intervention versus who can wait a bit.
Okay. Once we've stabilized and risk-stratified, the immediate pre-endoscopy pharmacologic management kicks in. And intravenous proton pump inhibitors, PPIs, are front and center.
Absolutely non-negotiable. The guidelines are crystal clear. High-dose intravenous PPI therapy should be initiated for all patients with suspected UGIB immediately upon presentation. This is standard of care. It shouldn't be delayed waiting for the endoscopy slot.
What's the rationale? Why IV PPIs right away?
Pure acid suppression. The goal is to raise the gastric pH above 6.0. In that less acidic environment, the platelet plug that forms the initial clot is much more stable. Acidic conditions break down clots very quickly. The typical regimen is an 80 milligram IV bolus, often pantoprazole or esomeprazole, followed by either a continuous infusion at 8 milligrams per hour, or you can use intermittent boluses, like 40 milligrams every 8 to 12 hours. This continues right up until the scope.
And this immediate PPI use has a real clinical benefit.
A substantial one. It demonstrably reduces the prevalence of those high-risk findings on endoscopy things like visible vessels, which means fewer patients ultimately need complex endoscopic therapy. And conversely, we need to stress, H2 receptor antagonists, they're discouraged. They just don't achieve that high, sustained level of acid suppression needed to effectively stabilize the clot.
Okay. Beyond acid suppression, is there anything else we can do pharmacologically before the scope to help the procedure itself?
Yes. There is. Sometimes an endoscopist's view can be really hampered by retained blood or large clots in the stomach. This is where a prokinetic agent, specifically erythromycin, can be useful.
Erythromycin as a prokinetic. How does that work and how do we use it?
A single 250 milligram IV dose, given typically 20 to maybe 90 minutes before the procedure, stimulates gastric motility. It basically helps clear out clots and retained blood. This can significantly improve visualization for the endoscopist, potentially reducing the need for a repeat scope or making the first one quicker and more effective.
Are there any caveats with using erythromycin?
The main one is that erythromycin can prolong the QT interval. So in a patient who's already unstable, maybe has electrolyte issues, we need to be mindful of that cardiac risk profile and monitor carefully if we decide to use it.
Right. Now, for that specific high-risk group, we suspect might be bleeding from varices, that changes the immediate pharmacologic approach, doesn't it?
It does. This is a parallel urgent track. If you suspect variceal bleeding based on history or known cirrhosis, you must promptly start vasoactive agents, usually octreotide or somatostatin.
How do those work?
They cause splanchnic vasoconstriction. This reduces blood flow to the gut. effectively lowering portal pressure and decreasing the blood flow through the varices. And crucially, this is started immediately on suspicion, not after endoscopic confirmation.
Okay, vasoactive agents first. What about antibiotics in suspected variceal bleeding?
That's the second pillar, and it's absolutely mandatory. Empiric intravenous antibiotics, typically a third-generation cephalosporin like ceftriaxone, must be started immediately for all patients with cirrhosis presenting with GI bleeding.
Why the antibiotics? Is infection that common?
It's incredibly high risk. Bacterial translocation from the gut is common during a bleed in cirrhosis. This leads to a high risk of spontaneous bacterial peritonitis, SBP, and other severe infections. These infections are major drivers of mortality in this population. Starting antibiotics promptly significantly improves survival. It's a key intervention.
Okay, so this comprehensive pre-endoscopy phase stabilization, risk scores, PPIs, maybe erythromycin, and specific agents for suspected varices sets the stage for the definitive step, the EGD.
Esophagogastroduodenoscopy, EGD, yes. It's the cornerstone for both diagnosis and therapy. And it needs to be available in a timely fashion, 247 in most hospitals dealing with these cases.
Let's talk timing. When should the EGD happen?
The timing is critical and it's evidence-based. The general rule is that EGD should be performed within 24 hours of presentation, assuming the patient is hemodynamically stable and resuscitation is well underway or complete. That 24-hour window gives us time to optimize volume status, correct coagulopathy if needed, and get those PPIs on board and working.
But there are clear situations where we need to go faster, pushing it into an urgent 12-hour window.
Yes, definitely. Earlier endoscopy, specifically within 12 hours of presentation, is strongly recommended for two main groups. First, patients who remain hemodynamically unstable despite our best resuscitation efforts. They need rapid diagnosis and mechanical control of the bleeding. And second, any patient where you have a strong suspicion for variceal bleeding. Because of that high risk of rebleeding and rapid deterioration, they need the scope sooner.
You stressed timely intervention, but we also need to reinforce avoiding premature intervention, right?
Yeah.
Sometimes there's a push to scope immediately.
That's a really vital point, and trials have shown this. There's no mortality benefit and potentially even increased risk from doing very early endoscopy, say, less than 6 hours compared to the recommended early window of 6 to 24 hours in stable patients. Remember, endoscopy is invasive. It requires sedation. Trying it before the patient is fully stabilized from a volume and coagulation standpoint might just increase risks like aspiration or procedural complications without actually improving survival. Stabilization has to come first.
Makes sense. So once the endoscopist performs the EGD, the findings directly dictate therapy and prognosis. What are the high-risk features they're looking for that demand immediate intervention?
We use the modified Forest classification to grade what we see. The high-risk features, the ones that need immediate therapy to prevent rebleeding, include active bleeding, whether it's spurting or just oozing. Also, a non-bleeding visible vessel, you can see the vessel pulsing in the ulcer base. Or an adherent clot that can't be easily washed off. If any of those are present, intervention is necessary.
And how do the treatments differ, say, for PUD versus varices?
Good question. For peptic ulcer disease, the common endoscopic therapies are mechanical methods like applying hemoclips to pinch the vessel shut, or using thermal energy, thermocoagulation, to cauterize it, or injection therapy, often with dilute epinephrine, to cause local vasoconstriction and tamponade. Sometimes a combination is used. For varices, the treatment is different. Band ligation is the preferred method for esophageal varices. It essentially places tiny rubber bands around the varix to strangulate it. For gastric varices, especially certain types, cyanoacrylate injection, basically a medical-grade glue, is often used to obliterate the varix.
And conversely, if the endoscopist finds low-risk features, like a clean base ulcer or just a flat pigmented spot.
That's very reassuring. Those low-risk stigmata are associated with a very low risk of rebleeding, often less than 2%. This significantly simplifies their post-procedure care. It often allows us to consider early discharge, maybe within 24 to 48 hours if they're otherwise stable.
Now, what happens if, despite best efforts, endoscopic hemostasis fails? What's the escalation pathway?
When the scope fails to control the bleeding, we have to escalate quickly. The next preferred step is usually radiologic intervention specifically, transcatheter arterial embolization, done by interventional radiology. IR can often selectively embolize the bleeding vessel. This is often successful for non-variceal bleeding, especially tricky ones like posterior duodenal ulcers or Dieulafoy's lesions. Surgery is really reserved as a last resort for the minority of cases where both endoscopic and radiologic attempts fail, or if the patient is truly exsanguinating and there's no time for IR.
Okay. So assuming successful endoscopic hemostasis, the focus shifts to post-procedure management and preventing rebleeding. Optimizing PPI duration seems key here, particularly that 72-hour mark.
It really is. For patients who had those high-risk findings, visible vessel, active bleeding, and received endoscopic therapy, we must continue that high-dose IV PPI for a full 72 hours. That period is crucial. It ensures prolonged maximal acid suppression while the clot organizes and the underlying tissue starts healing. It maximizes the stability of that clot we achieved mechanically.
Is the IV route absolutely necessary for the full 72 hours? Or could we switch to high-dose oral PPIs sooner if the patient is stable and taking fluids?
That's a great practical question. The evidence supports the duration 72 hours of high-dose therapy. While continuous IV infusion gives the most consistent pH elevation, some studies suggest high-dose oral PPIs, like 40 milligram twice daily, might be equivalent after initial stabilization. Clinically, if a patient is truly stable, taking oral meds well, and had maybe a slightly lower risk high-risk lesion, like an adherent clot that was treated, some centers might transition to oral earlier. But the standard guideline recommendation is still IV for the full 72 hours post-intervention for high-risk lesions, just to be absolutely sure.
And after that 72-hour intensive phase?
Then the patient typically transitions to standard oral PPI therapy, often twice daily for maybe 10 to 14 days, then followed by once daily maintenance long-term, depending on the underlying cause. And remember, if they only had low-risk lesions found on endoscopy, like a clean-based ulcer, then standard once daily oral PPI is usually sufficient right from the start.
Beyond the PPIs, what else is involved in post-endoscopy management?
Intense monitoring initially, watching closely for any signs of rebleeding, hematemesis, melena, vital sign changes. We also do serial hemoglobin checks, often every 6 to 12 hours at first, until we're sure the HGB is stable and any initial hemodilution is complete. And interestingly, our approach to nutrition has evolved quite a bit.
Right. We used to keep patients NPO for extended periods, didn't we?
We did. But current evidence strongly supports initiating early enteral feeding, usually within 24 hours after endoscopy, if the patient is tolerating oral intake.
And that's safe. Doesn't increase rebleeding risk.
Studies show it doesn't increase rebleeding risk, but it leads to better nutritional status, faster recovery of bowel function, and actually decreases the overall hospital length of stay. It's really a low-risk, high-reward intervention now.
Good to know. So when is it safe to actually discharge the patient? What are the criteria?
Discharge is generally appropriate when the patient has stable hemodynamics, hasn't needed a transfusion for at least, say, 72 hours for high-risk cases, is ambulating, has no clinical signs of rebleeding, and is tolerating an oral diet. As we mentioned, those patients with confirmed low-risk lesions on scope, especially if their initial GBS score was also low, might be candidates for much earlier discharge, sometimes within 24 hours.
And finally, before they leave, secondary prevention is critical to stop this from happening again.
Absolutely. This is the bridge to long-term health. Two major components here. First, ensure appropriate testing for H. pylori and treat it if it's found. Eradication is key. Second, and equally important, is rigorous modification of risk factors. Primarily, that means stopping NSAIDs. We have to counsel patients strongly to avoid NSAIDs completely if possible. If they absolutely must take them for another condition, they need to be on concomitant maintenance PPI therapy indefinitely.
Okay, let's pivot now and dive a bit deeper into tailoring management for specific, often more complex patient groups. Starting with variceal bleeding, you mentioned the urgency earlier.
Yes. For patients with cirrhosis and suspected portal hypertension, the urgency is really unparalleled. As we discussed, endoscopy within 12 hours is mandatory. And the management hinges on that triad of therapy that has to start immediately, often just on suspicion, even before the scope confirms it.
Remind us of that life-saving triad again.
Pillar 1, immediate IV vasoactive agents, octreotide or somatostatin to lower portal pressure. Pillar 2, prophylactic 4V antibiotics, usually ceftriaxone to prevent deadly infections. And Pillar 3, the definitive endoscopic therapy, which is band ligation for esophageal varices or cyanoacrylate glue injection for gastric varices.
Now, what about those really high-risk variceal bleeders, or those where initial therapy isn't working? We hear about TIP-BS, transjugular intrahepatic portosystemic shunt. When does that come into play?
TIP test is a major intervention, basically creating a shunt within the liver to bypass resistance and lower portal pressure. Preemptive TIPs, doing it early rather than waiting for failure, should be considered in specific high-risk patients. Criteria include things like a Child-Turcotte-Pugh score, which measures liver dysfunction, of Class B with active bleeding, or maybe Class C, or patients who failed to control bleeding within the first few days despite optimal medical and endoscopic therapy. This preemptive approach has been shown to improve survival compared to rescue tips later on. And long-term, after a versatile bleed, non-selective beta blockers like carvedilol or propranolol are the standard for secondary prevention.
Okay, turn to some other causes. Mallory Weiss tears, they often sound dramatic but are usually less severe.
That's generally true. Most Mallory Weiss tears are just mucosal rips that stop bleeding on their own. They often don't need any endoscopic intervention at all. We reserve therapy like endoscopic clips or maybe thermal coagulation only for those rare cases where you actually see active, ongoing bleeding from the tear during the scope. If the tear is seen but it's not bleeding, simple observation and acid suppression is usually enough.
Now, what about the opposite end of the spectrum? Malignancy-related bleeding. That sounds notoriously difficult to manage.
It is very challenging. The bleeding is often chronic, can be high volume, and frequently refractory to standard endoscopic techniques. The vessel walls and tumors are often abnormal, necrotic, fragile. Conventional methods like thermal coagulation can sometimes fail or even cause more tissue damage. For active bleeding from a tumor, sometimes topical hemostatic agents like special powders sprayed onto the area are preferred as a first line. They can cover a wider area and might cause less tissue destruction.
What if that malignancy-related bleeding keeps recurring, which it often does?
Yeah, the recurrence risk is extremely high. These patients really need a multimodality approach guided by oncology. If endoscopic measures keep failing, we look towards interventional radiology for angiography and potential embolization. Sometimes palliative radiation therapy to the tumor can help control bleeding. Occasionally surgery might be considered, but it's often high risk. The goals are usually focused on quality of life and bleeding control, following guidelines like those from the NCCN.
Okay, one last major special population. The patient who is therapeutically anticoagulated. This is becoming incredibly common. How do we manage them?
This is a real high-stakes balancing act. For any major life-threatening bleeding, holding the anticoagulant is obviously the necessary first step. For reversal, the choice of agent depends on which anticoagulant they're on and how severe the bleed is. For warfarin, PCC is preferred for rapid reversal, as we discussed. Vitamin K should also be given, but it works slower. For the direct oral anticoagulants, the DOACs, we have specific reversal agents, iduricizumab for dabigatran, and andexanet alpha for the factor XA inhibitors like rivaroxaban and apixaban, although its availability and specific indications can vary. FFP is generally not effective for DOAC reversal.
And the target remains INR less than 2.5 before endoscopy is possible.
Yes, that's still the general target if they were on warfarin. For DOACs, the timing of the last dose and specific reversal agents are more relevant than the INR. The really tricky part comes after the bleeding is controlled, when and how to resume their anticoagulation or antiplatelet therapy. This absolutely requires a multidisciplinary discussion involving cardiology, maybe hematology, the primary team.
Because you're balancing bleeding risk versus clotting risk.
Exactly. You have to weigh the risk of rebleeding, which is highest in the first few days, against the patient's specific thromboembolic risk. Why were they on anticoagulation in the first place? Atrial fibrillation with a high Cheat-Hands-2-Vasky score, a recent mechanical valve. It's particularly complex in patients with recent coronary stents. Restarting dual antiplatelet therapy, DAPT, too soon significantly increases bleeding risk. But delaying it too long dramatically increases the risk of stent thrombosis, which can be fatal.
So it requires highly individualized risk assessment, really synthesizing the GI perspective, the cardiology perspective, the patient's overall picture.
Absolutely. And that leads us to briefly consider the elderly and frail patient population overall. They inherently face higher morbidity and mortality from UGIB just due to their burden of comorbidities and reduced physiological reserve.
How does their frailty impact our management approach?
Management has to be highly individualized. We might need to use smaller volume, perhaps more frequent blood transfusions to avoid fluid overload, which they tolerate poorly. PPI therapy is still essential, but we need close monitoring for side effects. And we have to be incredibly vigilant for things like delirium, which can be triggered by the illness, the procedures, the medications, and can really spiral their hospital course downwards. Their ability to tolerate resuscitation and invasive procedures is often limited, so goals of care discussions are sometimes necessary early on.
Okay, so to summarize the core principles of managing acute hematemesis in the hospital, it seems like a time-sensitive, three-phase approach. Is that fair?
I think that's a good way to put it. Phase 1, rapid stabilization and resuscitation, critically adhering to that restrictive transfusion strategy in most cases. Phase 2, Smart use of validated risk stratification tools, GBS, to predict need for intervention. AIMS 65 for mortality risk to guide triage and the appropriate level of care. And phase 3, ensuring early and appropriately timed endoscopic intervention, generally within 24 hours, but urgently within 12 hours for suspected varices or ongoing instability. And all of this is supported by aggressive pre-endoscopy pharmacologic therapy, especially those IV PPIs.
And when these guideline-based steps are followed effectively.
The overall prognosis is generally good. Modern management has improved outcomes significantly. However, rebleeding remains the major complication to watch out for, especially if those high-risk stigmata were found on the initial scope. That immediate post-procedure 72-hour period with the continuous high-dose PPI and close monitoring is really the critical window where we work to prevent that recurrence and secure a successful outcome.
All right. So let's end with a final thought for our listeners to consider. We've discussed this evolution of prognostic scoring systems, moving from rockall to GBS for intervention prediction, AIMS of 65 for mortality, and now these newer, simpler tools like Harbinger potentially coming online. Given that we have multiple scores, each potentially useful for a slightly different purpose, and clinicians are always pressed for time in these high acuity situations, what's the optimal practical strategy for integrating these tools? How do we use them seamlessly in a busy clinical workflow? The challenge, it seems, is ensuring we don't miss anyone who needs urgent intervention by focusing too much on one score, while at the same time preventing unnecessary admissions or overly aggressive workups for that large group of low-risk bleeders who might be safely managed less intensively, perhaps even as outpatients after endoscopy. How do we best balance efficiency and safety using these evolving tools?
That's the ongoing challenge, isn't it? Optimizing the system to be both sensitive for the sickest patients and specific enough to avoid overtreating the low-risk ones. It requires constant refinement of protocols and likely better integration into electronic health records to make using the right score at the right time easier for the frontline clinician. Something to keep thinking about.